All right, welcome. So, if it's your first time attending Wayside Women's Wellness, thanks for joining. I'm going to share a bit about Project Echo and Wayside Recovery Center before we get started, especially for those folks who are new. I know some of the folks who've been here at some of these sessions know all about this, but for the folks who are just joining today, just a little background. Wayside Recovery Center is located in Minnesota, and we provide mental health and addiction treatment services for women, children, and families. Project Echo, which is the kind of second portion of this, the ECHO stands for Extension for Community Healthcare Outcomes, and it's a movement to demonopolize knowledge and amplify the capacity to provide best practice care. So together we have the Wayside Women's Wellness Echo. It's 1 hour long at noon each month. I know 1 hour doesn't seem like much time, but it's really meant to like plant that seed, get everybody interested. And it's sort of like a lunch and learn style series. The goal is to share practice and support service information, which will hopefully enable participating organizations to empower all people in recovery and empower women and families to break the cycle of addiction and trauma. So my name is Zora Darcourt. I'm the Director of Training at Wayside Recovery Center. And today our ECHO session is entitled Improving SUD Care with Trauma-Informed Care. This is the third session in a three-part series that Lydia has been doing on enacting trauma-informed care within SUD services. Just a side note that you don't need to have attended the previous two sessions to be here today. And also, I received some feedback from folks that they wanted more on the neurobiology of trauma, which Lydia covered in the past session. And so we have invited Lydia back. She's going to do a fourth session for us. Yay, we're super excited about that. And more details to come about that one too. So just be on the lookout. So if you haven't guessed already, our speaker for the day is Lydia Barthalo. And before we get started, I'd like to just share a little bit about Lydia, and then I'll pass things over. So Lydia is a doctorally prepared psychiatric nurse practitioner with a specialty in addiction medicine and trauma-informed care. She currently staffs and directs a trauma-informed urgent substance withdrawal management center and is on the faculty at UCSF, where she teaches in psychiatric nurse practitioner program. She speaks nationally on topics such as co-occurring disorders, harm reduction, and substance use disorder care system improvement, and she focuses all her parts of her practice on radical public health, harm reduction, and anti-oppression work. So thanks again for joining us, everyone, and I will pass it to Lydia.
Thanks so much. I'm so honored to be back, and I'm so honored that you guys want to have me for a fourth time. I'm really excited to come back and talk about neurobiology again. It's one of my favorite things to talk about. So that'll be mid-month, right? November 14th. Great. Is that right? Okay,
Yeah,
cool. So,
November 14th, or is it the 16th? I think it might be the 16th.
ooh, shoot, 16th. Okay,
It's our next Echo in November, so I'll be sending out uh, more information to everyone about that.
cool. Okay. Yeah, so thanks for coming in today. And I see some names already that look familiar from the first two, and I see a couple names that don't look familiar. No worries if you weren't here for the first two. I'm going to do sort of a brief overview of the major concepts from the first couple sessions. And just for the sake of time today, I'm going to dive right in, but please feel free to unmute yourself and ask questions. Put questions in the chat. I'll sort of try to keep my eye on the chat if I can. This is really, informal, and it is not meant to be a lecture. It's really meant to be more of a workshop. And so given that, we will just dive right in. I'm going to share my slides, and so that I can monitor the chat, you are going to see it exactly the way that I see it. Great. All right, so first, a little bit about me. Zora told you the most salient pieces, I think, but really, really quickly, I'm a psychiatric nurse practitioner, and so my brain very much thinks like a nurse. The role that I have and sort of what my day to day looks like looks very much like an addiction psychiatry physician. I lead a pretty big withdrawal management program, but sort of the way that I think about how to do patient care is more in line with nursing because that's how I was trained. And that's actually in some ways kind of important in the context of trauma informed care because in nursing, we're often interested in the experience that someone has in care as much as we are interested in the outcomes of care. And that's particularly important in addiction. And we'll come back to this in a second, but that sort of idea of paying attention to the experience that someone has in their care, it's really important in addiction because part of our work is engagement. Because people often don't engage with SUDS care because of the experience of stigma, or they do not appreciate the care that they get, or they feel judged, or they feel there's bias involved in their care. And there often is. The research says that there often is. So, in trauma informed care, we spend a lot of time thinking about what the patient experience is of being in care because we understand that that's central to patient engagement in substance use disorder services. I currently also teach down at UCSF in California. I live in Portland, Oregon, but I teach virtually down at UCSF. And I'm also a person in long-term recovery. So much of my work is sort of academic, and then I also have my sort of clinical hat, and then I'm also someone in long-term recovery. So I'm someone who's been through SUD services. So part of this is informed by my own experience in working through SUD services. All right, so I mentioned that we would come back to this. And so let's just spend a second talking about it. And if you weren't here for the first two sessions, this is really what we dug into in the first session. In order to implement trauma-informed care into substance use disorder services, one of the most central things that you have to understand is the way in which stigma prohibits people from engaging with substance use disorder care. So what the evidence says, and this is older evidence, but it sort of propelled us to look into this more. This comes from 2014. What this older evidence says is that the number one predictor of substance dependence, so you can tell it's old because it still says dependence, was stigmatization. So one of the main things that prevented people from engaging in substance use disorder care, especially if they had a return to use, was correlated with how much they thought they would be stigmatized in services. And it was usually based on people's previous experiences of being stigmatized in a healthcare setting. So the first thing we have to do if we want to be trauma informed is we have to think about what what services are propelled by stigma, what services are propelled by evidence-based practice, and how is it going to feel for the person as they move through our care? What's it going to be like? Because we know that if people feel better in our services, they feel like our services are trauma informed and not stigmatizing and non-judgmental, then they're much more likely to come back to services. And we know that especially with opioid use disorder, people tend to need 7 treatment episodes before it sort of sticks, so to speak. So we really, really want to pay attention to the things that allow people to both get into care and then come back into our care. How do we get people to want to come back into our care after there's a return to use? And so we have to tackle stigma first in order to be trauma informed. And that's something that took me a long time to learn. I kept going around teaching people about trauma informed care, and they'd have a really hard time enacting it. And when I sort of, when I sort of dug through the rubble of what was going on, it was often that people were carrying around a lot of stigmatization of people who use substances. And that was preventing them from doing the things that we'll talk about later today that are trauma informed. Do you guys have any questions about stigma or another thing I would love to hear? I'd love to hear questions about stigma, and I'd also love to hear what people that have been here previously learned as like the number one thing that we can do to decrease stigma. And my least favorite thing about Zoom is the lag, because you guys are probably putting stuff in the chat and I can't see it yet.
And feel free to unmute if you'd like to answer questions that way too, or share comments.
Absolutely. I can see some of your faces, and for some of you, I just see like ceilings or car roofs. It's pretty great.
Lydia, we do have one answer in the chat. Here,
Oh, great.
it says to decrease stigma, we have to do our own work to identify our own biases before we can learn to work with and past them.
Yeah, I love it. So Rochelle says decreasing stigma is all about identifying our own biases, and that's absolutely right. We have to understand where our own judgments and our own biases are showing up. And one of the ways that we can sort of actualize decreasing our own biases is changing our language. So one of the things that we spent a lot of time on the first webinar was talking about words that actually increase stigma per the medical evidence and words that decrease stigma. So some of you will remember that we talked about words like abuse. That's it's one of the more sort of useful to talk about. Abuse is a term that we've used to describe substance misuse or risky substance use for many, many years. And it's a bummer because it's in lots of important names like SAMHSA, right? We talk about substance abuse a lot, and yet the literature says that talking about substance abuse actually increases the stigma. And so it was a Robert Ashford, it's some Robert Ashford research, and it's pretty high quality research. And it's not just, hey, I think that this word is bad. It's done really, really well and really digs in and grabs some qualitative data about the word abuse and the way that it changes how we think about people who are using substances. So I'll just throw that one out there as one word you can try to not use on a regular basis. Don't talk about substance abuse, talk about risky substance use or disordered substance use. That's just one small thing you can do to sort of actualize and start thinking about decreasing stigma in our own minds. Rochelle also said, next, we can use genuine curiosity to learn about each person and work with them through their worldview lens. Yeah, absolutely. I would say that we did not talk about that very much in the first webinar that I joined you all for, but I think that's absolutely part of breaking down stigma and part of breaking down bias and judgment is just getting really curious about the person in front of us and understanding for them what drives their substance use and then what drives their recovery. Great, thanks. So then the next thing that we talked about, so our second webinar of the series was looking at the neurobiology of how trauma, especially in childhood, makes us sort of vulnerable to developing a substance use disorder in adulthood. So what the evidence says is there's a 4,600% increase in the chance of developing a substance use disorder in adulthood if you have an ACEs score of 6 or more, which is it's pretty telling. You don't see correlative data like that in public health very regularly. So it really tells us that there's likely a correlation between childhood trauma and developing a substance use disorder. So when I was with you all, what we did is we talked about sort of the neurobiology of how that happens. There's sort of a a narrative we share in substance use disorder treatment settings that people are often treating psychological pain. And that's probably a piece of what's happening, but it turns out that there's actually a change to our neurohormonal landscape if we experience a lot of adversity that makes us extra vulnerable to developing disordered relationships to substances. Processes too, but substances is what we're chatting about today, and it's where the bulk of the literature is. So we talked about a couple different things that shift with our neurobiology when we've experienced a history of trauma and adversity. And the first one that I want to just mention and review briefly has to do with trauma and inflammation. And if you weren't here for the second one, this is going to sound kind of bonkers. And I would just encourage you to come back for our sort of deeper dive in a couple weeks when I'll be back in mid November. But really quickly, if you were here for just a really brief recap, what we know is that trauma and adversity in childhood actually changes our immune system in adulthood and makes us more likely to become what we call globally inflamed. And that global inflammation, in turn, makes it so that dopaminergic substances are exceptionally powerful. And when I say dopaminergic substances, do you guys remember what I'm talking about? Or even if you weren't here, what's dopaminergic substances? What is what am I talking about? And again, feel free to unmute yourself if you would like to, or put it in the chat. Your brain wants more. Yeah, that's right. Claire said your brain wants more, and that's absolutely accurate. Dopaminergic substances that sort of turn on dopamine in the reward part of our brain are designed to be that way. Or let me say this differently. Your brain is designed to notate that there's more dopamine going off, and the dopamine is there to tell you to remember where that thing is, to remember that it's important, and remember that you should probably get more of it. So the easiest way to think about this is sort of from an ancestral perspective, which is, what was this built for when survival was of the utmost importance? And this was built so that we would remember high caloric content foods, fatty foods. We'd remember where they were, that they were important, and how to get more of them. Also, sex. So this is designed all for survival. Where is that thing? How do I get more of it? And keep engaging with it, keep going back to it. The brain is really set up to go, oh, that thing is really salient. That thing's really important. Try to come back to it as many times as possible. So, addiction, in some ways, is this very real, very sort of normal neurobiological process in our central nervous system just gone awry. So some people have even hypothesized that addiction is sort of a learning disorder because dopamine has to do with learning. And I really like that way of thinking about it. The idea here is that trauma and adversity changes our nervous system in adulthood and makes us have sort of place extra importance on those dopaminergic substances so that things that always would feel like they were important for our survival sort of move up that hierarchy of needs, and those things that always would feel like they're important for our survival end up taking over the central nervous system in a way and making it so that your body thinks that they are the most important thing, essentially. So that's the first point around neurobiology. And the second point is that we know that trauma and adversity shift our executive function and make it so that it's much harder for us to control our emotions. And anybody remember what executive dysfunction is, or just know it outside of our conversations here? Sometimes people know about executive dysfunction around things like ADHD or autism. Sometimes that's how people have come to learn a little bit about executive function and dysfunction. So, executive function is anything that your body needs to do or plan for future, or putting things in order and doing sort of higher level thinking that's removed from your emotions and is utilized to control your emotions. So, executive function is the part of your brain that goes, oh, whoa, I'm really spinning out. I'm really like future tripping about this thing that might happen. I'm really feeling anxious. Let me tell myself some self soothing narratives, like it's probably not going to be that bad, or nothing that bad has ever happened before. It's very unlikely that it's going to happen again. Or even if that does happen, I will survive. executive function is the thing that sort of leans in, helps us to organize our thinking, helps us to organize our days, decide what's more important over something else. And it's how we do a lot of our self soothing. Unfortunately, if we have a history of trauma or adversity, we tend to have executive dysfunction, making it harder for us to self soothe. So, if you have a history of sort of toxic stress or trauma, it becomes harder, even well into adulthood, to manage your emotions in sort of a regulated way. And so, people are going to do things like use substances to control sort of sympathetic or like hyper arousal emotions. And if you just think about it, it kind of makes sense. Like, what do we often want to do if we feel really emotional? What do we, what does Tony Soprano do whenever he has a hard day? Anybody watch The Sopranos? It's like it feels really old now. I feel like I'm dating myself, but it was a pretty incredible show. And sometimes I go back and rewatch it because I thought it was so good. Tell me if you guys disagree, but in my mind, there's sort of a cultural narrative that if you feel really emotional, especially bad emotions about something, one of the first things you're going to do is drink, right? Oh, I had a hard day. Let me have a couple glasses of wine. And so we utilize substances often to regulate emotions. And if emotion regulation is even harder based on our lived experience of trauma and adversity, then it makes sense that people are going to use substances more frequently to regulate emotions. And we see this all the time with our clients, right? This is why we do relapse prevention, is because stressful things are going to happen, stress hormones are going to increase, and people are going to have an increase in cravings. Same is true for good things happening, right? When we do relapse prevention, we don't just talk about bad stressful things happening. We also talk about, hey, what about that first time you're going to celebrate, right? What are we going to do? Because it's a big emotion. It's a big positive emotion, and just as much as good, those emotions sometimes they feel overwhelming, and we're going to regulate them in the way that helps our body. I mean, there's a reason that alcohol and benzodiazepines are so powerful. They just sort of turn off our central nervous system and they do all the regulation for us, or opioids. Methamphetamine, not quite so much, but they do really light up that dopaminergic pathway. And so meth use often falls under sort of bucket number one. And I'm going to skip number three here. We'll come back to it when I come back in a couple weeks. We'll talk about amygdala and sort of what that's for and what it means to have exceptionally high concentration of opioid receptors. So just know that I put that there because there's more going on. And I want you guys to have an understanding that there's some really like interesting neurobiological things that are happening in the context of our body really changing, our central nervous system really changing based on the experiences that we have really throughout our lives, but especially when we're younger. All right, so those are the first two parts because in my mind, those are the first two webinars we did, and this is the sort of series that I often do. Those are the most important building blocks we need for enacting trauma-informed care into substance use disorder services. If we don't understand some of that stuff, we can't then change how we're going to interact with people and how we're going to sort of think about the people that we're serving and what would be most supportive for them. And we need those building blocks to dive into what we're going to talk about today, which is how do we make how do we make substance use disorder services more trauma informed? And when I say substance use disorder services, I want to be really clear that I'm talking about the gamut of substance use disorder services. I'm talking about harm reduction services like needle exchange. I'm talking about sort of traditional recovery services, maybe residential or supportive housing with embedded recovery assumptions. I'm talking about withdrawal management services. So when I talk about these trauma-informed basics, they can be implemented anywhere that we are working with people that are using substances. And when we talk about trauma-informed care, and don't worry, you don't have to go in too far on this slide because we're going to come back to it and review all of this much more in depth. When we're talking about trauma-informed care, we're talking about the how, not the what. So I'll come back to that idea of the how, not the what, a little bit more, but it's often useful to just immediately call out that trauma informed care is different than trauma specific care. So a lot of times I'll tell people what I do and they're like, "Oh, that's so cool. So like you do EMDR with people with addiction histories." And I'm like, "Nope, that's not at all what I think about when I think about trauma informed care." When we think about trauma informed care, we think about systems and how to change systems, or how to have a specific conversation, or how to do a urine drug screen, or how to think about someone's return to use. We think about all these sort of like concepts and systems. We're not thinking specifically about treating trauma. So I put treating trauma in the trauma specific bucket. And lots of people that come into substance use disorder services need trauma specific services. So part of being trauma informed might be about building referral pathways to trauma specific services. You know, when someone gets towards the end of their maybe outpatient drug and alcohol treatment, maybe there's a referral to a trauma therapist who can help people really unpack some of that stuff. But when we talk about trauma-informed substance use disorder services, we're talking about how to make the services more engaging and more welcoming and less traumatizing and stigmatizing for people that come into services with a history of trauma. And what do we know about the number of people that are going to come into SUD services that have a history of trauma? What is true about the number of people who come into substance use disorder services and have a pretty significant history of trauma? You guys are so quiet today compared to the last couple. Is it Halloween? Like people are just so distracted by the joy of Halloween that it's hard to engage. Desiree says, I'd say they are, and I think there was more there. They are something. Desiree, if you think of it, feel free to fill that in. And Carol Moore says pain. Re-traumatized by the systems. Desiree filled that in. I would say they're re-traumatized by the systems. Yeah, so the number of people, no worries, Desiree, no worries at all. The number of people that come into substance use disorder services that have a history of trauma is going to be disproportionately high. People that need behavioral health services, especially substance use disorder services, have a much higher incidence of experiencing trauma than other utilizers of healthcare. People that need behavioral health services have often experienced incredible adversity, incredibly traumatic events, and a lot of what we would call structural violence. They've often experienced a lot of things like poverty, being traumatized by systems, etc. Have I ever seen anyone living with SUD who doesn't have a history of trauma? Absolutely. I definitely have. I definitely have seen people that have substance use disorders that don't have a history of trauma. I've seen it. It's really rare. It always stands out to me. And I'm like, huh, did I miss something? And I like remember those people, right? I remember that guy? That was really interesting. Yeah, he seemed, huh. And so it's not impossible to have a substance use disorder without having a history of trauma. It's not impossible. They don't usually end up in the kinds of services that I offer. So I tend to work with folks that take Medicaid. My last medical director job was for a pretty big FQHC focused on houseless populations. So the people that I work with on a regular basis don't have this. Probably if I was in private practice, I have a friend that does private practice and does like celebrity addiction medicine work. And sometimes those people are less likely to have a history of trauma, although not necessarily. Um, but I almost never see it. So the takeaway here that I want you guys to think about is that we want to be trauma informed, and we'll get more into what that is, because we know that we're serving a disproportionate number of people that have experienced really awful things in their lives. And when it's substance use disorders, they feel like they are being stigmatized and judged or experiencing biased care, even when we often think that we are doing our best. And so I love that you asked that question, Mary, because something I want us to think about is that when we enact trauma informed care, we consider it to be universal precautions. We just assume that people have experienced traumatic events in their lives. And so we're going to build systems or have conversations or develop clinical pathways and workflows that assume that everyone's experienced this. We're not going to necessarily need to know, when someone comes into treatment, we don't say, okay, well, tell us every traumatic event that happened to you because then we'll change your urine drug screen based on that. We're just going to say, we assume that everyone's experienced a lot of really hard stuff, that the incidence of sexual assault in our patients is higher than average. And so we're going to change the way that we do the urine drug screen process to acknowledge that many, many of our patients have experienced some kind of sexual violence in their lives. So, boom, we change our urine drug screen. We're going to assume that people have been stigmatized and judged in the past and that that is part of their traumatic experience. And so, we're going to change the way that we talk to people about having returns to use for everyone. We do universal precautions and we change our systems. And that's really different than trauma specific care, where we think about treating an individual and we often need to know what they experienced in the past. So I mentioned EMDR earlier, and we'll come back to it. But if you don't know about EMDR, it's a type of specialized psychotherapy that works when people have PTSD and other histories of trauma. And so when someone does EMDR, oftentimes the therapist might need to know what happened to them. And because it's a specific tailored clinical intervention, it's going to be really built around exactly what that patient needs. Whereas trauma informed care, we just assume people come in with trauma. And so we're going to change our entire system to be more welcoming and engaging for anyone that walks through the door. Trauma specific care also really targets specific symptoms of trauma. So, for example, I do a lot of prescribing Prazosin for nightmares because we know that people that have a history of trauma tend to have a higher increase of nightmares, whether they carry a diagnosis of PTSD or not. So, that would be the idea of treating a specific symptom that is sequelae of trauma, whereas trauma informed care builds systems for clients and staff. Trauma specific care is going to utilize very specific modalities like pharmacotherapies like Prazosin for nightmares or EMDR or somatic experiencing to lessen those trauma symptoms. Trauma informed care is really interested in how we think about the pathology. So, not just how do we fix it, but really how do we fix it as a way to understand how to support this person long term. And something I like to call out here, although I mentioned it earlier, is that in trauma informed care, because it's the how, not the what of what we do, we don't necessarily need to screen for trauma. It's really common that people have started to enact trauma informed care in their clinical systems. And they call me and they say, hey, we want to work with you. We want you to come offer a day-long training for our staff. And we want you to train us on how to be trauma informed. And we're super excited because we do an ACEs screening whenever anyone walks through the door already. And so we're already like getting down the road of trauma informed care. And there's a part of me that likes that because they're thinking about trauma and they're thinking about how trauma impacts people's life courses and their health outcomes and why they use substances. And also, we don't need to know. We don't need to know what kinds of things someone has experienced in order to know that we need to change the way we do things to be more attentive to people's histories of trauma and adversity. So I don't need to know about your sexual assault history. I don't need to know if there was violence in your home when you were a kiddo in order to recognize that a urine drug screen, and I just keep throwing that out as an example because it's usually something that people ask about. I don't need to know exactly what happened to you to make it so a urine drug screen feels less invasive and less sort of criminalizing, right? And oftentimes, what I find is that organizations will do a trauma screening and then they don't do anything with that information. So people come in and they do all this paperwork, and one of the pieces of paper they got to fill out is an ACEs score, and then we put that into their chart, and then we never look at it again. And so it's not always harmful. In fact, the research says that sometimes it's useful. But imagine if someone like asks you all those questions and sort of like opens up some of that stuff and then never kind of closes it up with you. Ultimately, the experience is often really invalidating for people. Like, why did you ask me all those questions about my childhood and then we didn't talk about it again? Or why'd you ask me all those questions about childhood and now we're talking about it and I don't have any like emotion regulation skills to think about some of those things that happened to me except for using substances. So, too many times in my career have I seen people start doing trauma therapy or start talking about hard old things before they've built new skills around how to manage hard emotions, hard memories, etc. Because using substances is an amazing skill for managing hard stuff that comes up. We just talked about that when we talked about the neurobiology. Using substances is one of the fastest, easiest ways to regulate our emotions. That's why people use them. So we don't want to open up these big, hard, really, really painful things for people unless we really are prepared to help them navigate it. So I tend to say, unless you've really got a solid plan, unless you know exactly what you're going to do with this, don't do a trauma screening. Change your systems. Change how you do a urine drug screen. Change how you tell people that you think they maybe had a return to use. Change how you talk to people about referring to a higher level of care. Change how you do your opioid withdrawal protocol to be more focused on decreasing dysphoria and more focused on comfort and believing people before you start screening people for trauma as they come into services.
Can I make a comment?
Yeah, please.
I really appreciate all you're saying. And something that comes to mind just as far as being in a lot of providers' offices and the intake, every appointment, blood pressure, weight, change in prescriptions, allergies. And then they go and the person who has roomed them is not even looking at them.
Mm-hmm.
And they're just on their computer. Do you feel safe at home? And they every single time, yes. Next question. And I know this person is being abused in some way or many ways at home.
Yeah.
And I see it, and I see this, it's not even worth my time to talk about it because they're afraid their children will be taken away. Or it's like you disclose, and then nothing is done.
Right.
So let's say that it's usually a medical assistant and nothing against that profession. They're overworked like everybody else. If they click on the no, I don't feel at home, nothing happens or scary things happen. It doesn't usually lead to a meaningful healing conversation that can bring some solutions.
Mm-hmm.
So anyways, and yes, thank you very much for bringing that up.
Yeah, absolutely. And it's so hard because we do want to ask people if they're experiencing adversity and trauma right here, right now, if there's something we can do to intervene. But that's a perfect example of trauma informed care. Trauma informed care would say, what's it like to be the person being asked that question in the midst of your allergy review and your med review? It could potentially be really traumatizing because you know that you're experiencing abuse, emotional trauma, physical trauma, sexual trauma at home, but you're going to have to silence yourself again because this clinical space actually doesn't have the supports or the nuance to understand what to do when you say, yes, I'm being abused, right? So that's a perfect example of let's think about what the patient is experiencing as we do this and make it more trauma informed. Because, yeah, we might want to do screenings for domestic violence or intimate partner violence, right? Maybe the literature says that that's something that's actually really useful. I honestly don't know, but my guess is that it is useful, but how we do it is just as important as doing it. And that's the essence of trauma informed care. The how we do it and how patients experience it is just as important, if not more important, than the outcome. And that's, again, especially true in substance use disorder services because we know that people return to use. That's part of the natural progression of this disease. People are going to use again, very, very likely. When the natural history of opioid use disorder is 7 times in treatment before it sort of sticks and you can make it to 4 years of sobriety, we got to build systems where people want to come back, right? Okay, so then you're probably like, all right, how do we build systems so people want to come back? And here is the special sauce to building trauma-informed systems. Trauma-informed systems always include 6 basic principles. And these principles should be thought of as improvement pathways. And the way that I want you guys to think about this is what kinds of things, and any of you can do this for the care system you're a part of. Where do clients tend to get dysregulated? And you guys feel free to put it in the chat or unmute yourselves. Where in your care do you see clients get dysregulated? And when I say dysregulated, I mean people get angry, people get sad, big emotions come up. Tell me where you see it in your care. There's no right answer here because you're all in different care settings. Making appointments and waiting lists. Oh my God, yes. So one of my favorite things I ever did is I did like a year-long intensive training for our phone support staff that aren't clinicians, have no clinical training in trauma and what that does to the neurobiology, etc., because they were often the people that were experiencing the most dysregulation from clients because people get really dysregulated trying to make appointments or getting put on wait lists, right? Those are really, really activating for a lot of people. So making appointments, waiting lists, 100% super activating for people. Rochelle said medications. I can think of so many areas where medications can be activating. A big one when I was in outpatient substance use disorder services is refills for buprenorphine. Like I really need my refill for my buprenorphine. I can't wait. Maybe I missed my appointment. Super activating for a lot of patients. Mary says cervical exams, babies descending during birth, not having prescriptions available, not being able to make an appointment. 100%. Those are all the kinds of things that absolutely are activating for clients. And I think of myself as like a pretty well-resourced person internally, externally. I'm a little bit of a mess sometimes, but like I'm pretty much okay. But I cannot tell you the number of times that I would try to make an appointment and end up screaming or crying at the person on the other end of the line. So imagine if you're new to recovery and you're not as well resourced as I am. You're not fluent in healthcare the way that I am. Of course, you're going to lose your shit, right? If I lose my shit, you're going to lose your shit. 100%. Yep. Okay. Rochelle says feeling loss of autonomy or decision-making rules, restrictions. Absolutely. Trauma at its core is about a loss of control. So when people experience a sort of loss of control within any kind of service where they perceive you to be an authority, big stuff is going to come up. And that happens all the time in SUDS, right? Because we have a pretty like paternalistic way of doing SUDS care where we say, you got to do what I say. That's how you're going to get clean and sober. You're going to do what I say. We absolutely like have rules and restrictions, and that's super activating because a lot of people have a history of trauma. Yeah, and telling people what they should do or need to do, absolutely. Okay, so think about all those places where clients and patients get activated. And you're going to improve those places. So you're going to, maybe you decide on like making appointments. You're going to improve those places using the following recipe. The first one is safety. What can we do to centralize safety more? Is there something that we can do to change the system to be more physically or psychologically safe feeling? And usually you're going to find out where people don't feel safe because that's where they're going to get really activated. That's where their emotions are going to get dysregulated. I think about safety a lot when I think about how to set up seating or how to set up physical space. So, Rochelle, I'll come back to your comment in a second. What I often think about with safety is, okay, how can my office feel the most safe for someone? And if you guys were gonna just put safety of the patient experience of safety, what would you guys do to a behavioral health office? What kinds of things do you add to make it feel safer?
Thinking about the positioning of furniture and things in the room.
Yeah, totally. Carol said low lights, and Zora said thinking about the positioning of furniture. Mary said gender neutral bathrooms. Absolutely. All of those things really, really imperative. Ooh, comfortable chairs. Yes, so imperative, especially in our opioid use disorder folks that often have a history of chronic pain. The lights, how to make the client feel they can exit. Ooh, thank you, Cynthia. Consider lighting, decor, making it feel less clinical. Absolutely. All those things. So you guys, ooh, fidget tools and pillows. Yes, you guys are experts in making places feel safe. And I just want to highlight here, Cynthia said how to make the client feel they can exit. This is such a classic thing. In behavioral health, we often have really, really focused on clinician safety, which is super important. We need clinicians to feel safe as much as patients. And clinicians have to feel safe to continue to do their job. But we oftentimes have prioritized where the clinician has access to the door and not the patient. So if we have to choose, we'll put the clinician near the door and not the patient. And what we don't think about is often people that have a history of trauma, that fight or flight can turn on. And what they want to do is flight, but it will become fight if there's someone in the way between an exit and them. And so a trauma informed sort of seating setting is really prioritizing both people having equal access to the door and no one being in the way of the other person accessing the door. So when I used to have this like tiny, crappy little, it used to be a primary care exam room and I needed to make it feel more trauma informed, I just let the client sit right next to the door. And as I brought them into the room, I would say, and that's your seat right next to the door. Just allowing them immediately to know that if something feels too big, someone feels too hard, we're talking about something really difficult, like I'm not going to refill their benzos or something like that, they have an exit immediately. So when I say when we're thinking about safety, that's the kind of stuff I mean. Because as Rochelle mentioned earlier, safety can be kind of a nebulous topic. It's like, well, safe for who? It's going to feel different for everyone. But I want you guys to think about, as a general rule, if you've experienced trauma, what do we think we could do to improve the experience of safety here? And people are going to feel much more safe when you do the rest of the recipe too. So don't worry, it's not just about safety. I will tell you some things that can make people feel safer. So the next part of the recipe, principle number 2, is trustworthiness and transparency. Decisions are made with transparency and the goal of building and maintaining trust. So where can you see the need for transparency in SUDS clinical services as a way to boost safety? Where do you guys see this already? There's so many examples of this. This is another place where no right answer, nothing I'm specifically thinking of, just we want to build transparency. Where do you think that would be helpful in substance use disorder care? Decision making, absolutely. We do so much decision making on behalf of clients. Sometimes we need to. Sometimes someone really needs a higher level of care, and it's going to be pretty hard to do true transparency. Sorry, you know what? I'm getting ahead of myself. It might be hard to do true collaboration, but we can absolutely be transparent with people immediately and say, here's what we're thinking. And what I often encourage is including patients in care conferences. So historically, we did a lot of like clinical supervision or care conferencing without the patient. And a really trauma-informed system includes the patient in that conversation. We can be as transparent as possible, and that makes people feel much safer. Because imagine how it feels to know that decisions are being made about you and your life behind closed doors and they don't include you. It can really be re-traumatizing for people, especially when they've experienced things like intimate partner violence. Feeling like you're losing control over your life, your bodily autonomy, etc., can be really, really re-traumatizing and make people feel unsafe. So anything you can do to increase transparency is going to make people feel safer. The third principle of trauma-informed care is peer support. And I'm going to go a little bit faster here just because I somehow got us way over time. My apologies. Peer support is imperative because it decreases the hierarchy, and that hierarchy almost always can make people feel unsafe. So anytime where there is a difference in power, so maybe there's a provider and they control your medications, they control your access to buprenorphine. Ooh, that power differential, that's big and that's hard and that carries a lot of emotions with it. And you and I all know that. What happens when a boss sends us a text message that says, meet me in my office in half an hour? Your boss could be the nicest person in the world and still, oh my God, you're going to go into full fight or flight, right? Because of the power differential. So peer support is that place where we can lessen the power differential. I also love peer support because they do a lot of like translating for me what the patient experience is. I remember a time I was writing a policy for including pregnancy tests at intake as we did the initial urine drug screen. And the peer was like, Lydia, what do you think it's going to feel like to a woman who's been using substances when you tell her you're going to do a pregnancy test at the very first visit? And honestly, it had never occurred to me. And immediately I was like, oh, duh, I think if I'm pregnant, you're going to send CPS in. DHS is going to show up and that kiddo's not going to be mine. So of course I'm not going to do that urine drug screen, even though I think of it as just being about safety. Or I'm not going to do that pregnancy test, even though me as a provider, I thought of it as just, oh, this is for safety. So peer support often helps me to understand where those sort of hot spots are going to be and helps me to think through what the patient experience of something will be. And one of the things I think is most important, if I had to pick one of all of these, would be collaboration. So because there's that power differential, we're going to be excessively focused on collaborating. So instead of making a suicide contract or a safety contract, we're going to do a safety plan. And this is just evidence-based best practice at this point. But what's the difference between a safety contract and a safety plan? Sometimes I'll hear other behavioral health providers and they're like, oh, it's just semantics. There's no difference between a contract and a plan. But there's actually a really big difference. The difference in those two things is collaboration. One, the client drives and you collaboratively support and guide. And one, the provider guides and then the patient agrees to it. And whenever a patient doesn't drive something, it's going to be less efficacious. So collaboration is central in SUDS treatment for a variety of reasons. And if I could pick one, I would say collaboration is the most important thing. We haven't done a lot of collaboration with clients in substance use disorder treatment. Again, because there's this paternalistic flair where like, we know best, you don't know best, your brain is what got you addicted, so we're going to tell you the things you got to do. But you know what? They're still the expert in their lives. Number 5 is empowerment. So the idea that we are not going to build systems where people become overly dependent on care teams, but instead we are going to empower people so they can show up with their full selves. And number 6 is humility and responsiveness. And this one's always a little bit nebulous. SAMHSA originally called this race, gender, and race, gender, and something else. And here's how I like to think about this. The 6th one that says humility and responsiveness on this slide, I like to think about this as structural violence. And that is just a fancy academic way of saying that there are systems that have harmed people, and they've harmed people disproportionately. Poverty, racism, gender-based violence, transphobia, those are systems that have traumatized people. And so when we try to be trauma informed, we're going to also think about, gosh, what would this feel like for a patient of color? Especially if you're like sort of a majority or dominant culture leadership or like clinical system team, what would it feel like for a Black patient to fill out this paperwork? Would it feel different than someone else? What would it feel like if you are a trans person? So the idea here is to think about the ways in which systemic oppression has affected people and traumatized people, and to also be as mindful of that as some of the things we sort of traditionally think about as big T trauma, like sexual assault or intimate partner violence or physical violence in the home when you were a child. We're thinking about these larger systems that have really impacted people, and we're thinking, okay, what about these clients that aren't part of the majority? How are they going to experience this? So that's number 6. And I really went over time, and I apologize. I want to read a couple things that are in the chat just because they're important and I want to highlight them. Rochelle said peers are a consultant to the team to help the team adhere to more person-centric practices and language. Absolutely, absolutely. And Rochelle says contracts set someone up for failure and a punitive consequence. Absolutely. You agree to this or else versus the patient saying, here's what I think should happen. Absolutely. And in our final 2 to 3 minutes, do you guys have any questions? That was a very rapid overview of how we think about trauma-informed care. So we started with stigma and how it prohibits us from doing things like truly collaborating with our patients on their outcomes. And then we talked about the neurobiology, really how trauma sets us up to be more vulnerable to developing substance use disorders. And then today, once we know those 2 things, today was what are the ingredients in thinking through how to improve systems to be more trauma informed. So what questions do you guys have?
Hi, Rochelle. I just read the question about the recording being available, and yes, I can send that to you. When I send out the survey, I'll send a link to the video too, the recording.
And I see a question about how to contact me and my last name. So I just put it in the chat. Oh, don't do that. That's wrong. I mistyped. My last name is Lydia Bartholow, and it's lydiabartholow.com. And there's just a button on my website, and it comes straight to me. So don't follow that initial link that I put in because I missed the T in my very own last name. You guys, I'm so glad that you could all be here today. I love talking about this, and I love sort of thinking through how do we make systems that have been really harmful for people in the past, how do we improve them? So I'm glad we could have the conversation, and then we could sort of dive in, like what does it look like to improve those care systems using some of these principles and some of these ingredients.
All right, then I'll stop the recording now.